The second time Michael ended up in hospital, it wasn't the breathlessness he remembered most. It was his wife's face when she walked onto the ward and saw the oxygen mask. He told me later that her expression said the thing none of his doctor had quite said out loud yet. This is just going to keep happening. Michael had COPD. He was 67. He had done everything right. Carried his inhaler, never missed a review, hadn't touched a cigarette in 11 years, and still 2 admissions in 8 months, sent home each time with steroids and a shrug, come back if it happens again. So he made peace with it. He decided this was simply what COPD became, that somewhere out there was a ceiling and he had hit it. He was wrong. 3 weeks later, someone finally looked at 4 things that had been sitting in his records the entire time. Not experimental drugs, not expensive private treatment, 4 standard NHS-available interventions that nobody had ever connected to his case. 12 weeks after that, Michael walked to the shop and back without stopping once. I am Dr. Suman Paul, respiratory consultant in the NHS and private practice here in the UK. In my 15 years of treating COPD patients, Michael's story isn't rare. It is one of the most common things I see. Stay with me because I am going to show you all 4 exactly what to ask for at your next appointment. Quick note first, I'm a doctor, but I'm not your doctor. This video is for education only. If you are struggling to breathe right now, call 999 or see your doctor immediately. Before I give you the 4 things, I have to fix something because the single biggest thing standing between Michael and the right treatment wasn't his disease. It was a belief. One I hear in my clinic almost every week, and it quietly stops people from ever getting what's available to them. The belief is this, that managing COPD means learning to live with less, that breathlessness is the new normal, that hospital admissions are just part of the deal. That's not medicine, that's surrender, dressed up as advice. And the first thing nobody had offered Michael is the one with some of the strongest evidence in all of respiratory medicine, pulmonary rehabilitation. It's a structured program. 8 to 12 weeks, supervised exercise, breathing technique, real education about your own lungs. It's free on the NHS, and for someone who had been admitted to hospital, completing it within 4 weeks of discharge dramatically cuts the risk of going straight back in. Michael had been admitted twice. He had never once been referred. Not because his doctors didn't care, but because fewer than 1 in 10 eligible patients in this country ever complete a program. If you have been in hospital with COPD or you are breathless doing things that never used to wind you, ask for pulmonary rehab by name. But rehab rebuilds the body, the muscles, the stamina, the confidence. It doesn't touch what was happening inside Michael's airways in the weeks between admissions. Because he wasn't just unfit, his airways were quietly inflamed and primed for the next infection. And there is a treatment built for exactly that. One most patients have never offered. Most have never even heard its name. It's Azithromycin, an antibiotic, but not the way you have ever used one. Taken 3 times a week, long term, it isn't there to fight an infection you already have. It's there to stop the next one before it starts. It calms the airway lining and clears out the bacteria that quietly colonize damaged lungs. The bacteria that turn an ordinary cold into a hospital admission. The clinical trials are clear. In patients who keep having flare-ups, despite good inhaler treatment, long-term azithromycin cuts exacerbation by around a quarter. Fewer chest infection, fewer ambulances, fewer nights like the one Michael's wife spent on that ward. He was the exact patient it was designed for. 2 admissions in 8 months, it had never been mentioned. It's not for everyone. You need a heart tracing before starting, and some people aren't suitable. But if you are a frequent flared-up patient, this conversation should be happening. If it hasn't, raise it with a respiratory specialist. 2 down, Rehab booked, azithromycin started, and then I asked Michael to do something simple. Show me how he used his inhaler. What happened next stopped me cold because the third problem had nothing to do with which inhaler he was on. Michael was already on a combination inhaler. His GP has stepped his treatment up after the first admission. On paper, it looked fine. Then he showed me. Slow, gentle breath in. No pause afterward. He had never been taught that his dry powder inhaler needs the opposite. A fast, hard dip pull to drag the medication down into the lungs. Breathe in softly and the medicine never gets there. It coats the back of your throat and goes nowhere. Over 70% of patients use an inhaler wrong. For 6 years, Michael had been taking a medication his lungs were barely receiving. So we switched him to a triple therapy, the 3 medication he actually needed. And then I did the thing that should have happened on day 1. I watched him use it, corrected him, watched again. 25 minutes, 6 years too late. If you are sitting there realizing nobody has ever watched you use your inhaler, tell me in the comments. It's one of the most common gaps I see, and you are not alone. I read everyone. I also run a free lung health community with a weekly newsletter. Plain English, no jargon, just what actually matters for your lungs. Links in the description. Now, the fourth thing, and this one's different. The first 3 changed Michael's daily life, but there was one more conversation owed to him. One most COPD patients never have, because most of the doctors don't yet know it's possible. And it starts with a sickle number hiding in the blood test he had had 18 months earlier. His eosinophil count. Eosinophils are a white blood cell. In certain COPD patients, a high level is a fingerprint, proof that a specific kind of inflammation is driving the damage and fueling every flare-up. The number that matters is 300 cells per microliter. Michael's was 410, measured a year and a half ago. Filed, forgotten. That number plus his admission history meant he qualified for something that didn't exist for COPD patients until recently. A biologic injection called tupilumab, approved on the NHS in March 2026. In the trials, it cut serious flare-ups by 34% in patients exactly like him. Not a small step, a different category of treatment entirely. And here is where I have to be straight with you, because there is a catch. A nice approval and a treatment you can actually get tomorrow are 2 very different things. But that gap isn't bad news. For Michael, it became an advantage. Approval means it's legal to prescribe. It doesn't mean every clinic can hand it out next morning. The NHS systems behind it, the pathways, the approvals, take months to switch on after a decision like this. So Michael didn't start the injections, not yet. But here is what we did do. We assessed him, confirmed he's eligible, documented his blood count, logged his history. The moment prescribing opens, he isn't at the back of a queue that hasn't moved. He is assessed, ready, first in line. Most patients will miss that window entirely because they don't know the treatment exists, have never had their count checked, and have never been assessed. By the time they catch up, the list is too long. That's the whole difference, knowing versus not knowing. So write it down. Ask your doctor for your eosinophil count. If it's 300 or above and you are still having flare-up on full inhaler treatment, say these exact words. I would like a biologics eligibility assessment. Have it now, not later. Now, let me show you what all 4 of these things actually did. Because 12 weeks earlier, the man sitting across from me was almost unrecognizable from the one on that word. At his 3 months review, Michael said something quietly. The way people speak when they're afraid to believe it's true. I walked to the shops last week. Both ways. Didn't stop once. No admissions in 12 weeks. His rescue inhaler, once a daily crutch, used twice in a week. His wife had stopped lying awake listening for him to struggle in the dark. He had finished rehab. He was walking 30 minutes every morning. The COPD hadn't vanished, it never does, but the disease was no longer running his life. For the first time in years, he was running it. Then he asked me the question I hear far too often. Why did nobody do any of this before? That question is why I make these videos. And the honest answer isn't that anyone failed him on purpose. It's something quieter. It's exactly why you can't afford to wait for someone else to join these dots for you. NHS reviews are short. The system is stretched. Rehab gets under-referred. Azithromycin long-term gets overlooked. Inhaler technique rarely gets checked. Eosinophil counts get measured and ignored. None of it is malice. All of this is fixable by you walking in prepared. So bring these 4 questions. 1. Have I been referred for pulmonary rehab? If you have been admitted or you are breathless, you qualify. 2. Am I a candidate for long-term antibiotics? Not everyone is, but every frequent flare-up patient deserves the conversation. 3. Will you watch me use my inhaler today? Not explain it, watch it. That word matters. 4. What's my eosinophil count and have I been assessed for biologics? If it's 300 or above and you are still flaring, that assessment should be happening now. If you are in the UK and want to go through this directly with me, I see patients privately at Pulmonary Medical in Manchester and Liverpool and at London Cromwell Hospital once a month. Check out my website for the booking link. But there is something underneath all 4 of these questions, and it matters more than any of them. Michael lay in that hospital bed convinced he had reached his limit, that his job now was to shrink his life to fit his lungs. I watch people do this every week. They stop walking the routes they loved. They move the bedroom downstairs, not because they have to yet, but because they are bracing for the version of themselves they have been told is coming. COPD is progressive, that's true. But how fast it progresses, how often you are in hospital, how good the years ahead are, none of that is fixed in stone. It depends on whether someone actually optimized your treatment or just accepted it. You don't have to wait for a second admission to start asking. The evidence says you shouldn't. So let me leave you with this. A COPD diagnosis isn't a ceiling, it's a signal. To get sharper, more deliberate, and more involved in what's happening inside your own chest. The patients who do best aren't the ones with the mildest disease. They are the ones who refuse the first answer, who ask about rehab, who heard the word antibiotics long term, who made someone watch them breathe, who found their eosinophil count before anyone bothered to mention it. For Michael, that number wasn't just ink on a blood form. It was the start of his next chapter. The treatment's approved, he is eligible, he is ready, and when prescribing opens, he won't be waiting. Please share this video with someone who has COPD, someone who's been told there is nothing more to be done. There may be 4 things on this list nobody has ever connected for them. I am Dr. Suman Paul. Take care of your lungs. They are the only ones you have got. And if you want the complete COPD treatment ladder, every step from your first inhaler all the way to the biologics and exactly what to ask at each one, I break it all down in this video next. See you there.